Time.
Hi, good evening, everyone. Welcome to another session of webinar by Beating Hearts. I'm Dr. Betty Tay. I'm the CEO and the founder of Beating Hearts. And I have here with me Dr. Sangeetha. She looks too young to be, a, a pediatrician. On top of that, an immunologist. Introduce yourself, Sangeetha.
Yeah, sure. All right. Thank you, Dr. Betty. Thank you, Beating Hearts, for this wonderful opportunity. I'm not that young. I'm actually in my 40s now. But yeah, so the important thing is I'm here to actually create awareness. And I have been doing so because although I'm trained in pediatric infectious disease, my passion is actually in immunodeficiency or primary immunodeficiency or inborn errors of immunity. So I did my fellowship both in Malaysia as well as in India, in Chandigarh in India, where I also train in allergy, in autoimmune diseases, and mainly in immunodeficiency. So I'm happy to share today and happy to take questions if there are. So I would like it to be more engaging and hope that it'll be a good session. Immunology is actually a very big topic. I think probably for some of us, the last we would have learned is probably in med school. But I try to make it as clinical as possible so that, and very practical that, because I've had a lot of referrals now from even general practitioners and of course physicians, and also here's to creating awareness.
Can you?
Okay, shall I share my slides?
Yeah, please.
Okay. All right, my slides visible?
Yes.
Okay, great. So again, just to share that I'm currently based in Sunway Medical Center Velocity. So I'm a pediatrician, pediatric infectious disease specialist, and I also see immunology cases for both children and adult. I'm currently also a visiting immunologist to HKL, specifically the neurology, and also in the respiratory hospital in IPR. And I do clinic sessions in UPM as well as yearly visits to Hospital Umum in Sarawak. Because my early days, I actually did my housemanship, MOship in Cebu, hence always the bond to Borneo. So okay, as we start, okay, so I think I'm not sure how many would have heard of this term, inborn errors of immunity, and I don't know how many would probably have heard me speak or heard the other professors and all speak on this topic. But I think just to start, I think I want to give a quiz. Just to get the ball rolling. So this is, I mean, I will go into this in a bit more detail, but just for an icebreaker. So just take a wild guess and put them in the comments or in the chat boxes. How many known genetic mutations are there for IEI based on the latest IUIS classification in 2024? So maybe Dr. Betty, you want to try?
I already know the answer. But I don't even know what is IEI.
Okay, so IEI
Answer.
is basically our topic today, inborn errors of
Oh, I
immunity.
see. Okay.
Yeah, and also known as primary immunodeficiency. So hopefully by the end of the session, you have a bit, maybe 10%
Okay,
of
team
what
said
it is.
500, but team is cheating also, I think.
Okay, so
Team was just now, uh, team was on the
on the
already, yeah,
presume.
right.
So correct. I
Okay.
mean, the answer is actually 500. And you will see how over the years, the genetic, because of our genetic screening, how it has increased exponentially. Okay, so just to give you an idea, I mean, what exactly is IEI or, primary immunodeficiency? So for example, this is how it might look like in a child. Okay, when you see a child with severe oral thrush, The two things that you probably think of is HIV, malnutrition, or primary immunodeficiency. And then you have this young boy who looks perfectly well, but we will go through in detail later. This boy as well. And you see a BCG lymphadenitis. So how do you move on further? Okay, so in adults, so now these are also a group of adults who all have a PID or primary immunodeficiency. Some look perfectly well, some have skin manifestations. So we'll go through and see in the cases, and you will see these pictures again. So just to take back to your medical school days, so these are actually our lymphocytes. They are part of the cellular immune system. During COVID, this was a big topic. Everybody was immunologists, and they knew the vaccine responses, whether the vaccines were working well. So people like us had to go into even more explanation, in-depth knowledge, to understand and give you the safest explanation. So these are the lymphocytes which play a very important role in our antibody or functional, basically our cellular function. Of course, there's other systems which are the innate immune system, which I won't really be covering in today's lecture. So this is probably one of the most important slides. So what exactly is IEI? So IEI, like we know now, is about 500 different conditions where a person may be either missing or have an immune system that does not function correctly. So that's the basic definition. And that is what IEI actually means. So why am I here? So why am I here to speak to you, and why am I here to talk about this topic? Firstly, we need to acknowledge that there are a lot of challenges in PID. So when we say delays in recognition of symptoms, in an average worldwide, even in the more developed countries, a patient with PID may only get a diagnosis after about 9 to 16 years. And these, instance probably goes up, especially when they are adult. There is, unfortunately, a lack of awareness. And of course, there is some variables in the diagnostic criteria and also the testing availability in Malaysia. So coming back to the IUIS, so this is the IUIS classification. So basically, they are just a group of experts that meet every 2 years, and they come up with the latest known genetic mutations. And as of 2024, we are at 508 different genetic mutations. So these are all happening from, we call them germline, but of course there are some somatic mutation as well. So these are the ones that alter the protein function. So some can be hyper, so some can be a loss of function. So it gives different presentations, okay? So coming back to these two graphs, so like what I mentioned, somewhere in 2007, you'd only see probably less than 200 different genes which cause or, are known to cause PID. But whereas in 2024, you see almost 500 and above. So these are actually increasing. The number of genes that are found are actually increasing, and which is better because, we should be giving better care, precision medicine and precision care to our patients. And you can see that these IEIs are further characterized into specific tables. Again, these are all a lot of words. So mainly we concentrate on those which are antibody deficiency. We have, dysregulation, phagocyte. So these are all basically patients who are born with a missing or a defective immune system, and they can present in any specialty. So I have referrals from neurology, from respiratory, from GI, from cancer, so everywhere, because since slowly the awareness is increasing, they have a patient who does not respond to normal treatment and they decide to refer. Even in cardiology, for example, one of the commonest syndromes associated with PID is actually DiGeorge syndrome, where they have a T cell defect. Okay, so now, so just to give you an idea, immunodeficiency is not the only part of immunology. It's actually one of the arms of immunology. There's so many parts to it. There's allergy, there's cancer, there's autoimmune diseases. So basically today, what we're going to concentrate on is IEI or immunodeficiency. Okay. Today's topic. So why is it called IEI? So why is because in the past, we thought immunodeficient means that they have some deficiency. But now we know that it's not just them having infectious manifestations, like very severe infections. They can also have non-infectious manifestations. So these will be explained later as well. So for example, what are the infection phenotype? So I had this girl who came in with huge lymph nodes, non-healing cervical lymphadenopathy. And of course, being in Malaysia, the first thing you think of is tuberculosis. And we went ahead, we sent the biopsy and all, but it actually came back as Salmonella species. And this girl, further, when we looked into her history and all, we actually confirmed her to have a Mendelian susceptibility to Mycobacterium disease. And of course, this is actually a misnomer, which I will explain in a case illustration later. And she also has a lot of siblings with similar illness. And again, this is a patient who has severe oral thrush, who was diagnosed as SCID or severe combined immunodeficiency, which is actually an immunological emergency. We actually have to transplant them early. And these are patients with nodules in the lung. And these are patients who have what we call chronic granulomatous disease. Okay. So now we come to the non-infectious complications. So non-infectious, like for this child that I saw when I was in India. Okay, so classical perianal swelling and looks like an abscess, but hasn't really fully matured. So it's actually a patient with leukocyte adhesion defect, where it's actually filled with inflammatory cells. So, you know, these patients actually have...
slides, please? Sorry. Change slides, please.
Oh, you can't see, is it?
No, just change first. I'll explain later.
Oh, okay.
Okay.
Yeah, and we have this child with
Just change slides first.
ALPS. Okay, sure.
Sorry, because I'm worried that the Facebook will block me.
I see. Okay, got it. Okay, sure, no problem. So again, as clinicians, what should we look out for? So as clinicians, I think this is one of the most important things in primary immunodeficiency, where we have the 10 warning signs. This is actually produced by MyPOPI, or the Patient Organization Group for Primary Immunodeficiency here in Malaysia. I will also tell you a bit more about this society. And so for me, one of the most important thing in history is actually a family history. Can give us a lot of clues, especially when it is X-linked and you know that the male has and the female is a carrier, or it is an autosomal recessive condition where some females and some males also have it. And why this is important is also because when we counsel the patient, we are able to counsel better. We can ask them for prenatal screening, or we can actually advise them on which child they need to keep, or, you know, we can advise them accordingly. Now, so these are mainly the details on the warning signs of primary immunodeficiencies. It's almost the same in children and adults, but for example, in children, you will have things like failure to thrive, whereas in adults, they're already grown. You don't really have that so much. But of course, the other things are quite common, where they have refractory anemia, pneumonias, pneumonia more than 3 times a year. Okay, severe infections, where they have bronchiectasis, abscesses, more frequent sinusitis episodes, and other things are, of course, like diarrhea, okay, and invasive infection, especially from non-tuberculous mycobacterium. So here, of course, we are endemic for tuberculosis, but when you have a patient having non-tuberculous mycobacterium, you should think of screening for primary immunodeficiency. Okay, so now the general rule. So the earlier the onset of immunodeficiency, the more severe it is, okay, especially in children. And certain PIDs like CVID, they don't manifest until adulthood or more than 4 years of age. coming to the investigations, okay, so whether you're in primary care or you're a general physician, what exactly can you do? Okay, firstly, I go to the very basics with just a full blood count. You can actually screen for the absolute neutrophil count. So you have a child having abscesses and severe infections, and you might notice that the ANC is actually low. Okay, then, or you have a child with a low absolute lymphocyte count, for example, in severe combined immunodeficiency, especially with the oral thrush. And of course, when you have high eosinophil counts, one of the differential is hyper IgE syndrome. Okay. Most labs actually have this, okay, which are the antibodies, your IgG, A, M, and E. So this is also easily sent. I mean, you can send, and also the subclasses. Isoheme agglutinin titers, by this time, I think most of the time you would have discussed with an immunologist. So it actually sees the antibodies towards your blood group antigen, and it's a surrogate marker to see your antibody response. Further tests that we do is actually to see the how you respond towards vaccination. So again, this is also a very specialized test, and it can be done, but you have to discuss and do it properly. So where you take the patient's blood and you inject them with a vaccine, and after that, after 4 weeks, you check for the response. Okay. So just a summary. Sorry, yes, Dr.
Wouldn't it
Betty.
be dangerous that they respond to the vaccine by, let's say it's a live vaccine,
So we don't give live vaccines.
or you don't
So we don't give live vaccines. So these are actually protein and polysaccharide vaccines. So there are two arms to how we test. So if one of it is a dependent, okay, antibody dependent and antibody independent. So there's actually two ways. So that's why one is called a T dependent and a T independent. So it's actually very detailed, but I didn't go into so much detail.
maybe next.
Yeah.
Yeah.
Maybe the next one. Yes, can. Yeah, but so
sorry, can I just ask?
Yeah.
If let's say it's a baby, we don't know, right? We vaccinate all babies at birth, and there are live vaccine.
Yeah. So before we do this test, we normally would have done a basic screening test, which are called your immunoglobulin and also your lymphocyte subset. So lymphocyte subset basically looks at your T cells, your B cells. So these are the ones that actually when, it's low or it's high, but we still think that there's some problem with the antibody response, these are tests that we can do.
No. What I'm trying to say is, at birth, all babies are given
Correct, BCG.
yes,
Yeah.
either BCG.
So I will illustrate
BCG,
that
right?
later in a case.
Oh, okay.
Yeah, I will illustrate that later in a case. I will give you an example of a child who developed that, a complication from that.
Okay, thanks.
Okay. So in investigation, so just to summarize again, you want to, of course, rule out immunodeficiency, secondary immunodeficiency, because it's still more common, like diabetes, HIV, cystic fibrosis, primary ciliary dyskinesia. And the tests which are needed, again, is just a basic full blood count first, okay? And then we do the immunoglobulin, okay? And also what we call as a lymphocyte subset. Now, generally, more clinicians are able to do this, especially when they are suspecting primary immunodeficiency. So I usually get referrals after all this is done. So that is something which is very good as a baseline. So genetics is again as appropriately sent, because at times we do get negative results, and it could be especially those who have like CVID or adult onset immunodeficiency, they may not have a proper genetic mutation. So these are patients where we actually need to look at the other results, like the immunoglobulin, the lymphocyte subset, before we make a decision. So this is what I mean by age matched. So this is especially important for children, not so much in adults, because actually based on the age, we also decide on whether this is a normal cutoff or not. So this is something we highlight as well. Okay, so I'm just going to go through just the principles today, because again, like we have 500 different type of problems, like immune problems. So I can't be going through everything. But in general, it will be certain vaccines can be only given to certain PIDs. You don't have to avoid vaccines for all PIDs. It depends on the type. You may need antibiotics and sometimes surgery. Okay, you need to replace the immune components, including giving some immunosuppression as well. So it's not all antibiotics. There is some role of targeted therapies. There are some patients who benefit from bone marrow transplantation. And again, the aim is to prevent infection and also replace the missing immune components. Okay, so that's my first part of the lecture. And so now I'll go through some of the cases so that you better understand and you better illustrate whatever I've spoken so far. It's not so easy to, like I said, it can be a very difficult and new topic. So let's go through some of the cases. Okay, now the first case, so we have a boy who was well until 10 months old with one pneumonia and always had recurrent otitis media, always requiring antibiotics. And the maternal brother died at 14 years old. Okay, the investigations showed a negative HIV, okay, full blood count fairly normal. Okay, and if you can notice that the IgG, IgA, and IgM is all low. So what could be the diagnosis? These are pediatricians or medical officers should know.
Okay.
The rest are all good to know.
Please? Anyone please put in the chat? Because I can't remember any of my pediatrics. All my internal medicine.
No problem. So so basically, this patient actually has Bruton's disease, or also known as X-linked A-gamma globulinemia. So basically, they have zero antibodies. So if you remember this boy from the first slide,
oh my God, so cute.
He and his twin brother has zero antibodies. Okay, so again, to illustrate, this is your B cell with antibodies. So imagine the B cell not having anything, okay, and so they cannot respond to infections, especially pyogenic infections. They can't clear. And this is the immunological basis. So basically, A-gamma belongs to a maturation arrest in the B cells where they have no antibodies at all. Okay, the CVID and all comes later. Okay, these are all part of the B cell development. And so in XLA, how do we manage? So basically, investigations, like you saw earlier, you saw all the immunoglobulins low. Okay, when you do the lymphocyte subset, you will see a low B cells, and there's an absence of BTK protein, and of course, genetics will show a mutation in the gene. So management will include IVIG replacement lifelong, okay, every 3 to 4 weekly lifelong. But people do very well overseas. There are doctors, even in Malaysia, the president of My Poppy, the patient organization group, his son has also SLA. But now what he does is SCIG. So they do a subcutaneous immunoglobulin and they do it at home. They don't even need to come to the hospital. So they do the infusions at home.
Wow, it was very costly.
Okay, so IVIG is actually given for free to Malaysians.
Oh.
Yeah, IVIG is actually given for free in the government hospitals to Malaysians. And this is given by PDN, Pusat Darah Negara. There are talks in the future for us to get even SCIG. And the cost in the past, before COVID, the cost was still quite high. But actually now the cost is comparable. In fact, even in private sector, actually IVIG price has gone down quite a bit. So it's actually becoming more affordable. So, and this is considered a life-saving medication by WHO, so they are entitled to be given. Yeah, so this is lifelong, and they don't need such high doses, like for example, what you give in Kawasaki and all. It's only a 0.4 to 0.6 grams per kilo. So it's not that high. And then some patients may need antibiotics and you can't give them live vaccines. In very a small subset of patients, we do consider bone marrow transplant. But again, bone marrow transplant is not without its risks, so only in a small subset. Okay. Now, second case is a young child, again, 3 months old, has got oral thrush, persistent pneumonia, faltering weight. Okay, and this is the child, if you remember from the first slide as well. Okay, again, if you see here, the child has a very low absolute lymphocyte count, okay, and HIV is negative. And if you see, all the immunoglobulins are low. So this patient has SCID or severe combined immunodeficiency. So in SCID or severe combined immunodeficiency, there are a few types. Okay, and this patient has a T minus, B plus, and a NK minus SCID. Okay, so, and of course, when we send the genetics, it came back as a IL2R. Okay, now, so this is just to highlight that although it's rare, in Malaysia, we have every year at least about 10 cases. There are works and there are in the pipeline to talk about newborn screening for SCID. And there has been pilot projects in certain hospitals. So that is something we are looking for. So I just want to share a little bit. This is one of my patients. Her name is Anur. Unfortunately, she has passed on. So this unfortunate girl actually was given a BCG vaccine at birth. And of course, because of the BCG vaccine, she developed disseminated BCGosis. And unfortunately, before we could take her for her bone marrow transplant, she had succumbed. So ideally, a patient with SCID should be transplanted within 3 months. The earlier, the better, because they are born with absolutely zero immune components. So that's why it is very difficult to support them. So that's why it's called a bubble boy or bubble girl disease. So you're supposed to keep them in a bubble.
Oh, like John Travolta, isn't it? There was a
Bubble
movie.
boy.
Maybe
Yes.
you guys are too young to know. Okay.
No, there are newer shows also. Correct, on bubble boy disease. Correct. Okay, so the third case is, okay, now we come to the adult patients. So it's a 36-year-old male. He was actually a doctor, okay, had recurrent pneumonia, sinusitis, prolonged diarrhea, CNS. So he basically had almost every organ involvement, every specialty. Took him many, many years to finally get a diagnosis. Okay, finally referred to our immunology unit. And his HIV was negative. If you can see, his immunoglobulins, his IgG and IgM were low. IgA was still normal. And, he had been going around to many, many different specialties, treated for whatever illnesses he had. But ultimately, his diagnosis was CVID, or common variable immunodeficiency. Okay. And the management of this, again, this is also known as an adult onset. So these are the PIDs, which are adult onset. They happen about 20 years and above. So it can involve both arms of the immune system, the B cells and T cells, and they can have infections, they can have autoimmune complications. So it's a bit tricky because you might think that this is just an autoimmune, but then again, when it involves many organ systems, it doesn't really fit a certain diagnosis. I think this warrants an early immunological referral. So the management includes IVIG maintenance therapy, antibiotics for infections, and targeted therapies. Unfortunately, this patient also succumbed recently. I mean, we started his IVIG for about 2 years now, almost close to 2 years, and unfortunately succumbed from a severe infection. Okay, the fourth case. So it's a 16-year-old girl, okay, had a history of BCG lymphadenitis, so a BCG lymph node at 1 year old. Her younger sister also had a BCG lymphadenitis. Her cousin sister also had multiple cervical lymphadenopathy. So if you can see, there is actually a very strong family history. So I realized that, I mean, that one thing that is missing is a lot of people, a lot of clinicians don't take time to actually ask family history. You can get a lot of information, you can actually diagnose a lot just from a good history. So, and then worked up for TB, was smear positive. So if you remember, this is the cousin sister. So she had, sorry?
I see. Okay.
Yeah. So this is the cousin sister. So she had cervical lymphadenitis. So basically, I think her immunological investigations were fairly normal, as it is usually. And we did her genetics, which confirm a MSMD or a Mendelian susceptibility to Mycobacterium disease. So if you see, this was the part of the IUIS classification, the tables which I listed earlier. So this is one part of it, just MSMD. You can see even in MSMD, there are so many genes which are involved, and she only has one of it. So this is how we use the table and we diagnose.
So what is the
So she has an innate immune defect. So basically, it affects the monocytes
Oh,
in
I
her.
see.
It affects the monocytes. So you can see the affected cells are actually the monocytes, and the genetic defect is a IL-12B, and it's an autosomal recessive. So that explains why girls, boys, everyone have it. So they are a consanguineous family. The parents are
Even
first cousins.
parents, I see.
Parents are first cousins. So that's why they have a lot of intermarriages.
I see.
Mm, yeah. So that's why she and a lot of her family members have this disease. So again, why I say this is a misnomer, because although it says to Mycobacterium disease, we know that they can have a lot of viral infections. They can have Salmonella, especially Salmonella species, which are actually low virulent. Normal people should not have severe infections. So, but these group of patients actually have severe infections. And like I said, there's a strong family history. And the investigations usually, basically from a thorough history, okay, and genetics, if available, okay. And treatment is actually antibiotics also for life, treatment of the infections. And unfortunately, we don't have IFN gamma, but most of the time with antibiotics, they do quite well until adulthood. So, okay, so now we have case 5. So 60-year-old. So the age, as you can see, is slowly getting
Yes,
older.
that's right.
So again, 60, but up to date, my oldest patient with PID is now 75 years old.
Oh, good. Means they can survive so long.
Yes, yes, because it's an adult onset, right? So
Okay.
you see this lady, so she's 60 years old from Sarawak. She's female, previously well. Okay, she had bronchiectasis, colitis, and she had a history of thymectomy for grade 1 thymoma. And of course, she had a lot of infections with fungal, bacterial. And so she actually sought an appointment with an immunologist in Singapore because she couldn't find anyone here to treat her. And the investigations done basically showed low immunoglobulins. Okay, her HIV, of course, was non-reactive. And her lymphocyte subset showed a low B cell and a CD4. So her diagnosis was good syndrome. Okay.
Good, not good.
So this is a misnomer. This is a misnomer.
Not
So
good.
it's not good for her, lah, but it's called good syndrome.
And the
So
good
this
is a what? What does the good means?
actually, I think it's found the person who found it was called Good.
Oh, I see.
So he named it after him. So it's Good syndrome. So this is her. This is her. She's quite well. That's her husband. So this I mean during the Sarawak visiting clinics we saw her. So she's doing okay with IVIG replacement therapy. She's actually being managed by the respiratory physician there as well. She has got antibiotics, antifungal, prophylaxis. And so basically, good syndrome is just immunodeficiency, which is characterized by low immunoglobulins with thymoma, a tumor. Okay. It is, most of them are adults. So most of them are adults. And basically, although thymoma, actually, when you remove the thymoma, they have less autoimmune complications. But a lot of times, the immunodeficiency persists. So they will still need IVIG replacement, they will still need antibiotics, and that is something that we need to manage.
So this thymoma is usually non-malignant, right? Because it's called thymoma.
Correct. But then for her, because it was removed earlier because she had some suspicion of autoimmune or other malignancy, so it was removed. She had a history much, much earlier before she was diagnosed as this immunodeficiency. Okay. So I've completed my cases, and so since a lot of the cases most of it was very doom and gloom. So I thought I probably want to share a bit of success stories. Okay, so so not it's not all sad and depressing. It's not really. We have had quite a number of good success story. So this is one of our patients who we met at a patient organization group event. So he was actually receiving IVIG monthly at one of the local hospitals, but he didn't know his diagnosis. Okay, he was told that he had CVID. He never really had any genetic diagnosis. So this was when I was still training in UPM with Prof. Intan and Dr. Azri. And so we actually sent his genetics and it came back. So after 24 years of having IVIG, he finally got a genetic diagnosis. So all this while, he just thought he had CVID, but actually he has XLA, X-linked A gamma globulinemia. So why this was important is because his sister was a carrier. Okay, so we were able to detect that his sister was a carrier, and also for his further, for the children, for the boys that the sister might have had. So we are able to better plan and manage the strategy, and also we were able to modify his treatment as well. So this is one. Okay, the other one is this cute young boy from the first slide. Okay, so basically he kept having recurrent mycobacterium infections, so very severe and very prolonged. So although he looks relatively well, but he was always in and out of the hospital. And so I saw him initially during my first encounter. Then after 2.5 years later, when I did my bone marrow transplant rotation in I actually helped to transplant him as well. So basically, we went from diagnosis to cure. He's completely free from his disease. Yeah, so he's well and he's thriving, and parents are very grateful. Okay?
Congratulations.
Yeah, so this is one. Okay, so this is fairly recent. This was from Velocity. So together with my colleagues, Dr. Henning, hematologist, and Dr. Rashida, the adult infectious disease physician. So this was a man in his 50s who had a lot of lymph nodes, which were non-malignant, and he had a lot of infectious by Penicillium manafe and other infections, which are fungal as well as non-tuberculous mycobacterium. So this man we confirmed to have an adult onset immunodeficiency with anti-interferon gamma autoantibodies. So we sent this test to Singapore and we confirmed it. And he is now undergoing treatment. So, and he's doing well as well. So this was another good and successful story. Okay. And so the one of the key players here is actually MyPoppy. So MyPoppy is actually the patient organization group in Malaysia for primary immunodeficiency. They now have over 100 and more families. So they host a lot of events. They help with a lot of crowdfunding. Okay, most of us are medical advisors there as well. So hence the MyPoppy t-shirt. So, this, most importantly, they create awareness, not just locally, internationally as well, under the iPoppy. And these are the ones that, bring in orphan drugs. They bring in the bone marrow transplant for those who, we can't do it locally. So this is an example. So this girl actually had, again, a successful transplant. She couldn't do her transplant in Malaysia. So after about, I think, 9 months, after crowdfunding, MyPoppy and everyone else crowdfunded, she actually got her bone marrow transplant in Apollo Chennai in India. And this came out in the Star, I think, over last weekend. So she basically had no immune system, and she's also now cured. Okay, so this is another good success story. Okay. So yeah, that's part of it. Okay, now coming to future. So what do we do, and how do we help others in the future? So basically, what I feel is really important is to talk more about it. Again, I'm grateful for this opportunity. Most of the time when people ask me to speak on PID, I don't say no unless I really have something urgent. Because I think the best way to get referrals and to give better care is through education. So we have training programs with the NGOs, with the pharma companies, and also, of course, public awareness to reduce stigma. So, sometimes, especially when you have chronic illnesses, there will be a stigma as well. They might think it is HIV or something else. We don't know. So this is also important. Okay, so moving forward, personal steps and what have I done? So basically, there is, when I first started this, I think there was a huge gap with the adult counterpart. So because there's no formal training, even in pediatrics, I mean, I had to do infectious disease in order to do immunology as a proper training. So it's about transition of care, diagnosing more adults, managing them better. I think we also need to have research collaboration. So I'm grateful that a few people have accepted adult immunology clinics. So I've started IPR clinics since January 2024. We do that every 2 monthly. And also visiting clinics yearly in SGH for the adult and pediatric cases. And just recently, I've started adult immunology clinics with Dr. Shanti, the head of department. So we do neurology from just this year only. Okay. So again, I just want to highlight that it is important for all of us to actually play a role. I mean, these patients need a voice, and please support My Poppy and any other awareness or campaigns that they may have, because again, we can, it's the best hope for cure. A bone marrow transplant is actually their only hope for cure. They don't need to be on lifelong antibiotics. They are well, and this is something we need. So with that, I think I shall end my presentation. There's a lot of people I need to thank, and yeah, that's all.
Oh, excellent. You're a very good speaker, Sangeetha.
Thank you.
Excellent,
Thank you.
excellent. Okay, I surprisingly today I saw a patient that I think is meant for you. So
Oh, okay.
today, yes, I never come across immunosuppressed patient unless they are HIV, and I do little of it. But this gentleman came to see me because he's been having short palpitation. And his history is he's only 26 years old, but 10 years ago, he had PTB.
Mm,
And then he was treated, and I asked him, was he compliant to treatment? And he said, yes, he completed the whole course of treatment. And he then, 3 years or 2 years later, he got PTB again.
mm,
Okay. And so when I looked at the chest x-ray, he has bronchiectasis, and the chest x-ray says that they cannot rule out an active TB.
right.
Okay. Now, the interesting thing is the mom had PTB when she was pregnant with him.
Mm,
So nothing struck me until I attended this talk.
yeah.
And
Yeah.
I
So
think he is for you. I have to call him to see you. He's very
yes,
well. He
I
looks very well.
very well. Yeah. So
Yes.
so it's highly possible, and actually that's TB is actually a huge problem, and I get a lot of referrals even from the ID physicians, the respiratory physicians. I mean, TB itself can be bad, but recurrent TB with bronchiectasis in a young boy, I think it warrants a bit more investigation, at least just to make sure we are not missing things that are treatable.
Okay. So that's one of my statement. Any question, please? Somebody say hi, Dr. Sangeetha. Aswa, nice to see you. Yeah, sometimes it's good to see people. Okay, another question I want to ask you is, you know that polio vaccine. Okay, polio vaccine, I think the program was started the same year I was born, maybe. So that's 1966. But I have seen people after 1966, means born after me, that had polio. Is it because they reacted to the vaccine, like
Yeah.
they are immunosuppressed, but they are otherwise very well?
Very well. So that's the other thing. So like how we give BCG here, which is a live vaccine. So Malaysia no longer gives oral polio, which is a good thing
Oh, I
because,
see.
yeah, we no longer give oral polio. But having said that, when I was in India, so we had a child, not a child, actually a boy with X-linked A gamma. Okay, and one of the thing that they have, you remember the boy with the Y? Okay, his twin brother has got chronic meningoencephalitis as a complication of enterovirus infection. So in Malaysia, that is a complication. I mean, so if you take IVIG, lifelong you're protected. But certain viruses you can't protect because it's enteric viruses. So one of it is enterovirus, the other one is polio. So when I was in India, because they still give oral polio in India, so these group of patients actually have chronic meningoencephalitis.
Okay. So what kind of vaccine do we give now? It's not the oral one.
Yeah, we give the injection now. We give a
I
part
see.
of the,
Since
it's like a
when?
6-in-1.
Oh, six. What's a six?
Hepatitis, DPT, everything together now. Hexasim.
Oh, okay.
So it's no more oral polio, but our concern now is still the BCG. So we still have patients because it's given universally. So that's why having a family history is very important. Because when you have a family history, then automatically we give a letter. So during delivery, the mother gives a letter to the ONG, to the PED, saying that do not vaccinate the BCG until the child has been evaluated for a PID.
Okay, can I ask you a question that's not
Yeah, sure.
related to this not auto immune deficiency?
Deficient.
Yeah. Do you think that the BCG works? Because there has been so many. I don't know.
Yeah.
I really don't know. But of course, I'm not anti-vaxxer.
Yeah,
But yeah,
understand.
I just want
Yeah,
to know, does it really work? Because there's been so much question about it along the
BCG,
way.
yeah. So basically, BCG, remember, it only protects you from invasive TB, for example, meningitis or other types of miliary TB. But the risk to get pulmonary TB is still there.
I
But
see.
it's supposed to reduce, and also because like severe TB, like I mean when I was in GH and all, the number of TB meningitis that we see is highest among those below 5. So by giving BCG, it actually reduces the risk.
Okay,
So
that's very important.
yeah. So it does help. It does help to a certain extent.
Okay.
Yeah.
So there is a question from Dokwiti. Just like how some hospitals screen for IEM in newborns, can we screen for IEI as well for if there's a strong family history? And can someone develop IEI without any family history, like a mutation, I guess?
Yeah, correct. So actually, that's the thing. So like what I was saying, actually there is a pipeline to have a newborn screening for certain rare disease like SCID, XLA and all. It is called a T-REC method. So basically, it's just a same skin, just like how you do the IEM screening, the blood spot. So there is certain hospitals now, they are doing the pilot. But again, if it is going to be rolled out with the whole Malaysia, is the cost involved and the technicians are not involved because you need to interpret the results. And also the other thing is once you have the results, do we have enough immunologists? That's also the other question. Who interprets them? Who transplants them? We do not have enough bone marrow transplant as well. So that's why we also send out to other countries. So there's all these technicalities. So that's why, I mean, it is in the pipeline, but those are the problems that we are facing. So that's for the first part of the question. The second part, can someone develop IEI without any family history? Yes, the answer is yes. So remember, I told you there's a few, like what you mentioned, number one is a sporadic mutation. Okay, so that is like the autosomal dominant mutation, correct? And the other way is also that, remember, these patients sometimes have got somatic mutation. Somatic is just like cancer mutation. So they don't happen like from birth, they can happen later on. So these are how we usually get our adult onset immunodeficiencies. But a lot of times the genetics may not come back as positive, hence why we need a lot of the functional tests. So we do a lot of functional tests, which again, not all is available in Malaysia. We have to send out, some are to research hospitals because the volume is not enough. So there are only certain hospitals or certain labs that do it.
Is it costly?
Yes, yes. I mean, the genetics now the price has dropped a lot. We generally send to one of this genetics lab called Invitae. It's a US-based company, or there's a lot of other whole exome sequencing. So it depends on what you are familiar with and how much of information you have or you know, then it is better. I mean, you get a better targeted genetic diagnosis.
Okay, so Andy has a few questions. For case 2, can we check HIV for a 3-month-old baby? Do we do HIV PCR?
Yeah. So usually we check the mother first. And then, of course, if mom is positive, then we can do a HIV DNA PCR. This is what we normally do for even HIV. And let's see something.
Yeah, for
For IEI patient, cannot get live vaccine throughout life. So again, like I said, it is not it is not the same for all. So there are different type of IEIs. For example, someone with XLA or someone with SCID, yes, you can't give them live vaccines. But someone with chronic granulomatous disease, also, I mean, you can't give live bacterial vaccines, but that doesn't mean you can't give live viral vaccines. So you need to know the type of immunodeficiency. So I cannot give you a blanket rule. So basically, you need to discuss with the immunologist. Yeah, but that is one. But of course, to be on the safe side, don't give first until you have discussed. So
okay.
that'll be good. Yeah.
Okay, the third question I think is quite important.
Oh, BCG. Okay.
Yeah.
Okay. So when to suspect IEI? So yeah, okay. Another important question. So basically, BCG lymphadenitis is very common. And
Is it?
it is. Sometimes it's because it can be a complication of BCG.
Oh,
So normally what we say, it is unilateral. It's the same side as the BCG vaccine. It happens below the age of, like, usually it peaks to about 3 months. So it shouldn't last until about a year. Okay, that is one. And then you shouldn't have multiple sites. Okay, the child shouldn't have other systemic signs. Okay, normally, I mean, some people, they actually just do a FNAC or an excision biopsy. So normally what I do is the same thing. I will see for failure to thrive. I will see the sites of BCG, where it is. And I will also see whether there's a family history. I will do, if I'm more suspicious, I will do some basic immune workup.
okay. Any more question? I think it was excellent actually. I would say it's excellent.
Thank you.
Excellent because of your presentation. You're a very good speaker. Excellent because of the flow of the presentation, and excellent because it created awareness among all of us. I had no idea about anything.
Thank you, thank you. I hope people will join, because we have a lot of national allergy and immunology conferences. There's one coming up in 2 weeks. I will also be speaking there for the nursing symposium, as well as the conference itself. So that is being held in UPM. So it's a NACLIS, National Allergy and Clinical Immunology Symposium. So you can learn more about and in depth about immunodeficiency there.
Okay, I don't really care because I'm going to invite you for the next
Thank
next
you, thank you.
webinar soon anyway. So what should we speak on? Okay, and Andy, why you got so much question? What are you doing?
Oh,
You just,
Andy should be
yeah, that's right. I
should be
think
doing
he's probably
immunology.
doing fits or whatever. Okay, what's for cyclical neutropenia? How
Okay. Okay, so I think Andy is a hematologist, and I might know Andy. So I think so cyclical, okay, again, it is I didn't touch a lot of the PIDs. So cyclical neutropenia is basically a type of a variant of neutropenia. So it can be congenital, it can be cyclical, and there's a lot of things that we have to monitor. Is in basic, usually what we do is we monitor the full blood count every 2 to 3 times a week for 6 to 8 weeks, and then we see the infections. There are a lot of things to consider. So I would advise just refer to one of us. I'm happy to take referrals even from government or UPM. So there's a lot of places where we can refer. Yeah.
Okay, so I think Dr. Krishnan asked, what's the average cost? I think we cannot tell because there's too vast.
Too vast, yeah.
Yeah.
But just the basic screen, I mean, it's actually not expensive. Every hospital has immunoglobulins. So, just even if you're concerned, the basic thing you can send for I'm also going to give a talk next month to MTS, Malaysian Thoracic Society, on bronchiectasis and PID. So again, the other thing I'm going to highlight is basically just sending immunoglobulins as a baseline.
Okay. Andy is a big fan of yours. I'm a bit
Yeah.
worried now.
Hi, Andy. I think I know this Andy.
He
I
sounds like he's a big fan.
No,
Okay,
no,
Dr.
no,
Krishnan
not
asked,
yet.
I have CA colon, CA bladder, and multiple myeloma. Oh, I'm so sorry to hear that.
Sorry to
I-
hear as well.
yeah,
Yeah.
would it be advisable for my children to do?
Um, I I mean, generally no. I mean, if it's just CA, but again, I'm not an expert on this. I think he probably has to discuss with his oncologist, see whether they have done any genetic tests. Just
Yeah.
monitor your children and see. But again, I don't really know the association.
Yeah, I don't
Yeah.
think it's more oncology genetic.
Yeah, correct.
Oh, I'm so
Correct.
sorry to hear that.
Yeah.
Okay. Last question.
Yeah.
What is this cardiology immunodef
Oh, DiGeorge syndrome, where they have T cell, yeah,
no, I
not
don't. Actually,
so it's basically a cardiology, it's a cyanotic heart disease
oh,
with
pediatric.
absent-thymus. Yeah, it's a pediatric, yeah. But they sometimes they go into adulthood as well. So yeah, it's basically a congenital heart.
Okay, I'm not
Yeah,
interested.
DiGeorge, yeah.
I see. Okay.
Yeah.
So I think with that, thank you very much, Sangeeta.
Thank you,
Actually,
Betty.
yeah, you don't do justice to I mean, I like you like this because in your LinkedIn profile, you look so serious. But I will stop live stream now. Stop live stream. Sorry, okay, stop live stream and stop recording. Thank you so much, yeah. And from next week onwards, I will not be working in Beacon anymore, yeah.
Oh, okay.